Hello and welcome to the 2021 Virtual CHW Summit. My name is Quisha Umemba and I am the CEO and founder of Umemba Health LLC. And before I begin this presentation, I'd like to review some housekeeping items with you. This is a pre-recorded session, but the Q&A section of the Thinkific platform is being monitored to respond to any questions that you may have. You can access the discussion tab at the top right of your course player whenever you have a question to ask. The course player is where you are watching this video now. So in the top right corner, if you have a question, just click on the image of the two alternating boxes, then click Create New Post to submit your question. Keep in mind that questions will only be answered on the day that the presentation premieres live. Today's slides and any additional resources pertaining to this presentation have been made available to you inside of the Thinkific platform. You can find them by scrolling down past this video. As a reminder, we do ask that everyone complete a survey about this session. The survey is located inside of the Thinkific platform. You will be prompted to complete the survey after you click complete and continue at the end of this presentation. If you don't receive a prompt, you'll still be able to find the survey in the summit outline. Please also complete the summit evaluation at the completion of this week. These are extremely important and they really help me. I use every bit of feedback to inform future educational events. And just a reminder, this presentation has been approved for continuing education hours for community health workers, community health worker instructors, and certified health education specialists. But in order to obtain your certificate, you must complete the summit surveys and the summit evaluation by April 23rd. So please, please, please don't miss your window. And last, if you're on social media, please join in communicating with us. We'd love to interact with you. We're on Facebook at Virtual CHW Summit. We're on Instagram at CHW Summit, and you can see the hashtags that we're using there. Please make sure to tag us. Just let us know how you're enjoying the summit. And let's let everybody else know what's going on this week because we got a lot of great things in store for you all. That's all I have for housekeeping. Let's get on to the session now. Hope you enjoy the summit. Hello, everybody, and welcome to the presentation. We're going to be talking about racial and ethnic health disparities and steps to prevent and reduce. There are a lot of potential causes for racial and ethnic health disparities, but for the purpose of this talk, we'll be looking specifically at how racism and implicit bias contribute to health disparities and poor health outcomes in vulnerable populations. So first things first, these are your objectives. Define racial ethnic health disparities, define the causes of health disparities, specifically from the lens of racism and bias. We'll talk about how bias impacts health outcomes of vulnerable populations, and then discuss ways that you as the CHW can help reduce or prevent healthcare disparities. I'll try not to talk too fast. There's so much content that I want to cover in 30 minutes, so let's jump right into it. When we talk about health disparities, the term is often defined as a difference in healthcare, right? But when we talk about disparities, we really don't get into the nitty gritty. This is a mouthful of a definition, but I really think it paints a really accurate picture of what's going on when we talk about health disparities. So let me read it to you. Health disparities is often defined as a difference in which disadvantaged social groups, such as the poor, racial ethnic minorities, women, and other groups who have persistently experienced social disadvantage or discrimination systematically, experience worse health or greater health risk than more advantaged social groups. So again, that's a lot, right? But it's true when this term is applied to certain ethnic and racial social groups, it really describes the increased presence and severity of certain diseases, of poor health outcomes, and greater difficulty when it comes to things like obtaining healthcare services for these marginalized populations. So that's health disparities. And again, we're going to be talking about it from a racial and ethnic lens. In case you haven't heard, racism is a public health issue. Racism involves one group having the power to carry out systemic discrimination through institutional policies and practices of society. And when those institutional policies and those societal practices shape cultural beliefs and shape values that support those policies and practices, This makes racism a public health issue. And while most of you are aware of explicit racism, right? This is right in your face racism. I don't like you because you black, because you Jewish, or whatever. This is that conscious choice to actively hate or discriminate someone based on race. Most of you are familiar with that. And this is, I agree, a growing problem in the country, but it really is only a tiny part of actual racism. Today, most people, most communities of color who are negatively affected by racism are affected by what's called systemic racism. Interchangeably used sometimes, it's referred to as institutional or structural racism. And although more harmful than explicit racism, this form of racism is less understood or even recognized. So I'm going to refer to it as systemic racism throughout the rest of the talk. I want to show you a quick video that will give you a better idea and explain way better than I could ever explain it to you, but I'm going to attempt to explain it to you. So systemic racism really is like this interlocking, interwoven set of parts that together make up this established way of doing something. And not only does it establish a way of doing something, but it really kind of says, well, this is the assumed way. This is the normal way of doing things. This is what is acceptable, and this is how we're going to keep it. Systemic racism is built into every layer of our society. And this video that I'm going to show you is going to show you exactly how it's built into every layer. So let me show that video to you now.
This is Jamal. Jamal is a boy who lives in a poor neighborhood. He has a friend named Kevin who lives in a wealthy neighborhood. All of Jamal's neighbors are African American, and all of Kevin's neighbors are white. Because Jamal's school district is mostly funded by property taxes, his school is not very well funded. His classrooms are overcrowded, his teachers are underpaid, and he doesn't have access to high-quality tutors or extracurricular activities. Kevin's school district is also funded by property taxes, so his school is very well funded. His classrooms are never crowded, his teachers are very well paid, and he has access to high-quality tutors and lots of extracurricular activities. Kevin and Jamal live only a few streets away from each other. So how come they're growing up in such different worlds with such different opportunities for success? The answer has to do with America's history of systemic racism. To understand it better, let's look at what life was like for Kevin and Jamal's grandparents. Decades after the Civil War, many government agencies started to draw maps dividing cities into sections that were either desirable or undesirable for investment. This practice was called redlining, and it usually blocked off entire black neighborhoods from access to private and public investment. Banks and insurance companies used these maps for decades to deny black people loans and other services based purely on race. Historically speaking, owning a home and getting a college education is the easiest way for an American family to build wealth. But when Jamal's grandparents wanted to buy a house, the banks refused because they lived in a neighborhood that was redlined. So Jamal's grandparents were not able to buy a home, and because colleges could prevent them from attending through legal segregation, their options for higher education were really scarce. Kevin's grandparents, on the other hand, got a low-interest loan to buy their first house and got accepted into a handful of top universities, which traditionally only accepted white students. This opened up a wealth of opportunities that they were able to pass on to their kids and grandkids. Even as late as the 1980s, an investigation into the Atlanta real estate market showed that banks were more willing to lend to low-income white families than to middle or upper-income African-American families. As a result, today, for every $100 of wealth held by a white family, black families have $5.04. A 2017 study confirms that redlining is still affecting home values in major cities like Chicago today. This explains how Kevin and Jamal inherited vastly different circumstances. Unfortunately, the story doesn't end there. A big part of systemic racism is implicit bias. These are prejudices in society that people are not aware that they have. Let's go back to Kevin and Jamal. Against all odds, Jamal manages to be the only student from his high school to get accepted into a great university, the same one that Kevin and his high school friends are attending. But after Kevin and Jamal both graduate, Jamal notices that his resume isn't drawing as much interest as Kevin's, even though they graduated from the same program with the exact same GPA. Unfortunately for Jamal, studies show that resumes with white-sounding names get twice as many callbacks as identical resumes with black-sounding names. Implicit bias is one of the reasons why the black unemployment rate is twice the rate of white unemployment, even among college graduates today. You can see evidence of systemic racism in every area of life. The disparities in family wealth, incarceration rates, political representation, and education are all examples of systemic racism. Unfortunately, the biggest challenge with systemic racism is that there's no single person or entity responsible for it, which makes it very hard to solve. So, what can you do?
So we're going to talk about what you can do a little bit later. Let me go back to the presentation here. I really like that video. I think it does a really good job of showing again how systemic racism is really embedded into all of the fabric of society. And it's really hard to attack and address something when it's embedded literally in every layer of our life. So in the video, the narrator spoke about implicit bias. So we're going to switch gears and talk about implicit bias right now. Implicit bias refers to attitudes or stereotypes that affect your understanding, your actions, and your day-to-day decisions. And implicit bias is affected by a number of things. So your life's experiences, what you see on television or in movies, your social circle, and all of this kind of helps to shape your beliefs and your attitudes about other people. And it's usually based on race, ethnicity, age, appearance, culture, customs, etc. Unlike explicit bias, implicit bias, implicit bias occurs subconsciously and without innate awareness or intentional control. Now let's go to origins of implicit bias. So humans base their perception of reality on received information and experiences reinforced until they become automatic. And one example of this is stereotypes. Stereotypes, you've heard them before. I'm sure you've heard them about several different cultures and ethnic groups, but they're learned sets of associations between some trait and a social group. They can be accurate at the group level, but inaccurate at the individual level. And let me give you an example so you understand what I'm trying to say. I was raised in Arkansas and I currently live in Texas. If I say all Texans root or cheer or support the Texas Longhorns, that could be correct at a group level. But I was raised in Arkansas. I'm a Razorback fan. So it's really inaccurate on the individual level. That's how stereotypes work. Implicit bias develops early in life from repeated reinforcement of these social stereotypes. And they lead to biases that sometimes lead to prejudices that sometimes lead to discrimination if you're not self-aware. Let me give you another example when I talk about this repeated reinforcement. Pretend I'm a white woman. So if I'm a white girl at 3 years old and I hear my parents say, "Oh, be careful. Get away from that man. He's sagging his pants. He's a thug. He's a criminal. He's a hoodlum." And then I hear throughout my life, 9, 10, 11, 12, don't you go out with those guys. Don't be friends with those people. They wear their pants below their waist. They're thugs and hoodlums and gangsters and criminals. And at 16 and at 18 and at 21, if I want to date a black guy, my parents are, "Well, what did we tell you about black guys that wear their pants below their waist? They're thugs, they're criminals, they're hoodlums, riffraff." You get the idea. Those repeated reinforcements, and that's just one example, right? But that's what leads to the implicit bias. Implicit bias is not discrimination, but it does lead to discrimination. Have you heard about the black, white, good, bad test? It's officially known as the implicit association test. Harvard University actually does this research. And if you want to take the test, and I encourage you to, just click on that take the test button there in the PDF version of this presentation. But this is a test that's used frequently to assess for implicit race bias. I have taken this test twice, once in grad school and once after I've been working as a public health professional for a few years. This test is basically a speed test where they show you different pictures of black and white faces and they ask you to categorize words such as good, bad, wonderful, glorious, agony, horrible, evil, joy. And you're supposed to do this as quick as possible. They associate these words, some words that are clearly obviously bad and some that are clearly obviously good, with a black face or a white face. And they give you 2 rounds to do this. So, again, participants must answer as quickly as possible because this increases your reliance or the reliance on automatic responses. And this is ultimately how they test or measure the bias. If the result is a shorter response time for white is good, black is bad associations compared to white is bad, black is good associations, then this reflects a pro-white implicit bias. And then they look at the magnitude of the difference in milliseconds and correlate that with the degree of one's implicit bias. And again, I've taken it twice, and I even skew toward a pro-white implicit bias as well. Back in grad school when I did it, I can't remember, but it was much wider. And when I did it a few years ago, it was barely, I mean, maybe 1 or 2 points difference, which means, or I think, I have done the work to make sure that I'm trying my best to be self-aware and acknowledge just the stereotypes and the bias that I've been privy to, that we've all been privy to growing up in the society in America. This is something that's really interesting, and I really recommend that you take it. When the IAT is used with professionals in the medical field, specifically clinicians, providers, they are seeing that they implicitly associate Blacks with being uncooperative, especially when it comes to medical procedures. So, a good place to start, and we'll talk about self awareness a little bit later, but a good place to start is to actually test yourself to see if there is any implicit race bias. So, what's the problem with implicit bias? The problem is that it leads to unequal treatment, which in turn leads to unequal outcomes. Let's look at some of these outcomes in vulnerable populations. Marginalized populations like homeless or people of color are more likely to be seen as criminal or violent in emergency situations. They're more likely to be presumed to be non-compliant with their medication, and they're more likely to be labeled as medication or drug seeking or having an ulterior motive other than trying to get the care that they rightly deserve and need. Hispanics are often assumed to exaggerate pain or emotional distress, which often leads to them receiving inadequate care. Other racial and ethnic minorities consistently receive less adequate treatment for acute and chronic pain than non-Hispanic whites, even after controlling for age, gender, and pain intensity. And some of these differences are just too obvious to ignore. We live in a culture where it's kind of see no evil, hear no evil, speak no evil. But as community health workers, advocacy is one of your core roles, right, that you serve in. So if you don't speak out against these differences in care, then you are being complicit or complacent. Racial complacency is supporting racism and racist systems by not challenging it at all. I mean, that's basically you're racist. And racial complicity is when you're either consciously or unconsciously supporting, contributing, or most importantly, benefiting from racism or racist systems. And a lot of times when people are not speaking out about it, it's because they're benefiting from that system being in place. Our implicit bias can make us insensitive to cultural differences. And when that happens, it really impedes culturally responsive care. And I know I'm preaching to the choir here. I'm sure that all of you are aware of what cultural competence is, but I'll just say it here just for those that may not be. Cultural competency is the ability to care for patients with diverse backgrounds, values, beliefs, and behaviors, and then being able to tailor your services, your care, your delivery to meet the patient's needs socially, culturally, and linguistically. And in order to do the work that you're doing, you've got to be culturally competent. But I'm here to tell you that learning about other cultures is not enough because these learnings are usually limited. Whatever we learn is easily influenced by our personal biases. So we have to do more than just show cultural competence. We have to show cultural humility as well. And what is cultural humility? It is a process of self-reflection and discovery in order to build honest and trustworthy relationships. So how do you go about starting this work? First things first, you need to take an introspective look. You need to acknowledge that we all have biases, including myself. You need to ask yourself these questions. Do my biases do any of the following? Do they impact the amount of time that I spend with patients? Do they influence how I communicate with my clients and their families? Do they hinder my capacity to feel and express empathy? Do they interfere with my capacity to interact positively with my patients and clients and their families? Be an ally. You should be deliberately and intentionally, as a community health worker, placing yourself in a position of support rather than the position of a savior. Recognize that, yes, you do have power in your position, but you should be using that power to help amplify the voices of the unheard and for those that cannot speak for themselves. Help identify resources and remove obstacles if possible, but empower your patients and your clients to find, evaluate, and access the resources and services that they need. This is the share approach, and this is what I want you to implement in your practice to help reduce and mitigate healthcare disparities. The share approach includes seeking, helping, assessing, reaching, and evaluation. The share approach is a 5-step process for shared decision making that includes exploring and comparing the benefits, harms, and risk of each option through meaningful dialogue about what matters most to the patient, because that's really all that matters. What matters most to the patient. So let's go through the share approach one by one. So the S in the share approach stands for seek your patient's participation. You want to make sure that you communicate with them that a choice does exist in their care and that they are involved, invited to be involved in the decisions. Patients have a right to understand their treatment options. They may not choose to participate, which I know is frustrating, right? You want to help them, but they don't seem interested. But guess what? They have a right to choose to participate. Let's engage them in their healthcare whenever possible. So here's some tips for you to do that. Summarize the health problem for them. Make sure they understand it. It's on their level. Let the patient or your client know about any options that exist for them. Ask your patient to participate with the healthcare team in making healthcare decisions. Include caregivers, include family members if the patient is okay with you doing that. And remind the patient that his or her participation is important, and thank them also for being active participants in their care. The second step is helping your patient explore and compare treatment options. And here's some tips for you to do that. Assess what your patient already knows about his or her options. Write down a list of the options and describe them in plain language, being aware of the health literacy level. Clearly communicate the risk and benefits of each option, explaining the limitations of what is known and what is not known about the treatment options, and also telling the patient what would happen without treatment. If this is something that you don't feel comfortable doing, you can certainly serve as a liaison um, to the provider, because often the doctor is going to do this part, right? That's really what we want the provider or the clinician to do. But you can also reinforce that information that is being shared so that they understand what happens if they get the treatment or if they don't get the treatment. The third step is to assess your patient's values and preferences, because you want to take into account what matters most to your patient. And an optimal decision is one that takes into account patient values and treatment. So some of your tips here: encourage your patient to talk about what matters most to him or her. This means you got to actually ask them, right? And when you ask them, ask open-ended questions. Listen actively to them, show empathy, show interest in wanting to help them solve this problem. Acknowledge the values and preferences that matter to them and agree on what is important. Sometimes I ask my patients, prioritize your goals. If you are trying to lose weight, what's most important to you? If you're trying to make a healthy lifestyle change, rather, that's a better, what's more important to you? Is it more important that you lose 50 pounds, or is it more important that you actually can walk a mile without getting short of breath? Agree about what's important to them and help them prioritize those options. The fourth step in the share approach is to reach a decision with your patient. The doctor should not be making this decision. The CHW should not be making the decision. The healthcare team should be reaching decisions with the patient, deciding for the best option, and helping to arrange for the most appropriate follow up. So, some tips for this step: help your patient move to a decision, again, by asking if he or she is ready to make a decision. Sometimes our patients aren't motivated to act on a decision because they need more information. So, if your patient needs more information or additional tools, brochures, handouts, maybe they need to see a video. How do they learn and retain information? That's where you can be involved in helping your patient have access to those things to help inform their decision. Check to see if they need more time. Maybe they feel rushed. Maybe there's other things going on in their life that they need help with. And so they can't even think about this medical choice yet until they pay their rent or until their mother gets over COVID-19. You never know what it is. So you've really got to talk and engage your patients, and then schedule follow-up appointments to carry out the preferred treatment, or the active surveillance. Because sometimes the doctor will say, okay, you just want to wait and see right now. Well, then we'll just wait and see. If things get worse, you can come back in 3 months. We'll test you again, or we'll get another x-ray or something like that. But make sure that whatever that decision is, that we follow up, you as a CHW follow up in the matter that's appropriate. And then the last step is to evaluate your patient's decision. And you do this by supporting your patient so that the treatment decision that they have come up with has a positive impact on their health outcomes. For many decisions, particularly those related to the management of a chronic illness, decisions can and should be revisited. So when I say evaluate your patient's decision, this is, Mrs. Jones, I know you decided not to have the surgery when you went to the doctor last month. I just want to know how you're feeling about that. Do you feel like that was the best choice? Have your symptoms gotten worse? Is there anything I can, you'd like to talk to me about, or any other information you'd be interested in learning more about? Constantly, continuously reevaluate your patient's decision to help them make the most informed care. So, monitor the extent to which the treatment decision is implemented, assist them with managing barriers to implementing the decision, and again, revisit the decision with your patient and determine if other needs, if there are other things that are needed. So, recapping the share approach: seek your patient's participation, help your patient explore and compare treatment options, assess your patient's values and preferences, reach a decision with your patient, and evaluate your patient's decision. This work is not easy. I understand this work is not easy, but change really does start with you. You have to have self awareness. Acquiring personal awareness requires an internal compass that's used to guide your daily interactions. And this compass is what's going to help you recognize acceptable versus unacceptable attitudes and behaviors, and help you on the right path when you're faced with the continual threat of unconscious bias. You have to acknowledge that problems do exist, and maybe you do have a problem with bias. But until you're actually honest enough with yourself to acknowledge, no action can be taken to solve the problem. Also, with acknowledgement comes accountability and responsibility to make a difference. As a CHW, you have to take practice. You have to make your practice of empathy a daily practice. You also must advocate for your clients. So you should be able, your patient should be able to sense that you are there to do what is best for them to provide safe outcomes. And lastly is education. Continue to educate yourself. Enhanced knowledge is really key to raising awareness, to recognizing the existence of unconscious bias, and to producing the prevalence of unconscious and implicit bias that leads to healthcare outcomes. So the change really starts with you. You have to do the work. I think I'm coming up on my time now, so I want to leave you with some inspiring words before I conclude. This is a quote by Mahatma Gandhi, and he says, "Watch your thoughts, they become words. Watch your words, they become actions. Watch your actions, they become habits. Watch your habits, they become character. Watch your character because it becomes your destiny." What do you want your destiny to be? What do you want to leave behind? I'm sure you became a community health worker or whatever helping profession that you work in because you want to leave this world better than you found it. So you really have to do the work. It really starts with you. I hope you've enjoyed this presentation and it's been helpful. Continue to enjoy the rest of the summit. Thank you for listening.